Next session is a video demonstration of a key specimen moderated by Dr. Jung-Sun. Today's topic is conduction system. Dr. Jung-Sun, please.
Thank you very much. It's really an honor to have this online video session this year. I'm pleased to invite Dr. Yoon, and she's an excellent pediatric cardiologist, but also has a very good potential of cardiac morphologist. And also I will invite soon the Professor Jung-Sun, who will follow my initial presentation on normal anatomy. So this presentation is divided into three parts. The first part is conduction system in the normal heart, in particular emphasis on the internodal pathway. And the second part is VSD, TOF, DORB, and Epstein's anomaly, and AVSD by Jung-Sun Kim. And finally, I will back to discuss about the corrected TGE and Fontan operation. So the first topic is normal conduction system. We have been discussing, would you close up this heart, please? We have been discussing this normal heart so many times, so you will be very familiar with this heart, a very small child's heart. And we can see here is a superior vena cava and ascending aorta, right atrial appendage. The junction between right atrial appendage and sinus venous part of right atrium, here is a sinus node at the epicardial, subepicardial position. And we have been discussing the significance of conduction system in many different aspects, but recently it's a really challenging issue for can you give it bigger and bigger, please? Zoom in, please. So it's because the patients with congenital heart disease almost always survive until adulthood. So we hope they will enjoy the normal life. But the challenging issue is the arrhythmia after in adulthood. Most of the arrhythmia may be related to cardiac surgery, but in fact, the reality is that the older heart has a normal, not normal, but abnormal atrial arrhythmia occurring. So it's also important for both adult and children that how is the internodal conduction system. So we know a sinus node here, and AV node is in here. But I have been studying this particular pathway and we always agree that there is no particular specialized pathway from sinus node to AV node. But reality is that there are certain preferential pathway between these two nodes. We understand that the muscular mass bridging this sinus node to AV node make a preferential pathway. The most easy thing we understand is that crista terminalis, which is a very thick muscle from sinus node area descending between the appendage and sinus venerum. So we started the several hearts on what is the thickest part of atrial wall to show the conduction between these two hearts. There are two methods. One is I was very lucky to use very old heart specimen where every fatty tissue is lysed, so that we can only see muscular tissue in Taiwan, and they beautifully demonstrated the major muscular tissue in here. And also the other way is that we could make a 3D modeling study that this is right atrium, sinus SVC, and if we subtract make an erosion of this muscle, we can remove the thinner part of the atrium, so that here's the sinus crista terminalis, and here is the transverse pericardial sinus, and this is AV node area. So if we erode more, we can see this kind of shape. So we can only see crista remaining and some in sinus nodal muscle reaching to the AV node area. So some of these findings I could make how I can show what the anatomical location of internodal muscular skeleton, the kind of muscular mass from the chamber modeling. So in here we have crista terminalis here. And then there's an interatrial septum separating right atrial and left atrial part, and right upper and left upper pulmonary vein, and left appendage, and Coumadin ridge, and so on. So I made an arbitrary drawing to this heart to show like this. Clearly, this is a sinus node area where sinus SVC and right appendage meets here at the crista terminalis. So this is crista terminalis, make branching pectinate muscles from this area, and it comes down to this level in front of the IVC through eustachian ridge or eustachian valve area, and then go to the AV node posterior at the superior the tendon of Todaro area. This is sinus, coronary sinus. So the upper border of orifice of coronary sinus is here. So this is the crista terminalis, which is the easiest things that we understand, and also it goes back to the through the coronary sinus, and this is the so-called posterior internodal pathway. The anterior internodal pathway it can draw from the sinus node to this AV node here. So we understand the Bahaman's bundle is muscular bundle between right atrium and left atrium at the transverse pericardial sinus at the anterior wall. So this is the Bahaman's bundle. But reality is that this Bahaman's bundle is a representation of middle part of internodal pathway from sinus node to here and branch to Bahaman's bundle and approach to posterior aspect of AV node like this. So there are some branches of this Bahaman's bundle to going upward between left and right upper pulmonary vein and at the lateral ridge, and then below the left appendage there is a left circumflex artery and coronary sinus where the supramitral vestibular muscular tissue is maker tissue. And also to the right side, the tricuspid annulus has a thick part so that it approaches back to the here. So this is the inferior aspect of coronary sinus. So what we cut when we do cavo-tricuspid isthmus resection is that cavo-tricuspid is cutting this and this. This is subeustachian sinus, which is a thin muscular tissue. It's a characteristic of right atrium, and this is a thinner part. So these are anterior and posterior pathway. The middle pathway is running behind the SVC at the posterior wall of sinus venarum to make this ridge. You can, Dr. Yoon, what do you think is the anatomical name of this part? You can see. So it's a septal structure. Thick septal structure from sinus node to AV node is the
Limbus.
yes, limbus. Superior limbus part is the here, so it approaches to the superior limbus to AV node. So to the AV node posteriorly, there are two pathways. One is from anterior, the other is superior limbus. And also there is the Waterston groove, which covers the posterior part. So there are some paper describing interatrial pathway like this, but I don't think that's true. That's just a vascular tissue. But reality is that muscular tissue turn to the left side through the superior limbus part of fossa ovalis. So going back to this area, and also going down area. So we can map like this that the from Bauman's bundle we have three muscular tissue to the left atrial wall, and middle internodal pathway has branches to atrial wall, and posterior so-called we understand anterior, middle, posterior, but posterior is a rather right side rather than posterior. So we may describe anterior, posterior, or right, but because we may confuse this posterior, anterior, middle, and right posterior, something like that would be fine. So these are basic backbone of interatrial muscular pathway. So what we cut in the MACE procedure or RF ablation, I don't think we usually cut this part, but we cut some minor branches from this pathway, or this significance of this pathway may make some macro reentry pathway that may cause atrial arrhythmia. So we have to study more based on the anatomy and CT modeling like this, and also physiologic study. But I think based on the specimen observation, not every specimen has the same anatomical structure like this, but some has very attenuated this part, and some other has the other part. So this is the basic backbone, and some of every cases, but still there are some variation in case by case between these the structures. So if you, as an electrophysiologist, we will think about looking inside of the heart so that you will recognize from inferior aspect to the SVC, right atrium. This is SVC, and here is the starting point of crista terminalis, where subepicardial sinus node is around here. So the anterior pathway is going back a little apart from the fossa ovalis. Anterior pathway go like this, and then at the transverse precardial sinus, they have the Bauman's bundle to the right side and Bauman's to the left side, and so on. And also the second middle part goes from here to here, and then approaches like this through this point. So this is more posterior than anterior pathway at the anterior part of limbus of fossa ovalis, and they together make anterior input of AV node. And the posterior pathway is from here to here, and then cross the IVC through here, eustachian valve. Okay. so that this is the posterior pathway. And the one ramus of the anterior pathway turn around this tricuspid valve annulus and approach like this and to here. So we are cutting cavo tricuspidus was cutting here and here so that make a division. So in some case, this part may be minor. In that case, that will be more important. And some other case, the other way around. So this is coronary sinus orifice. So this is a summary of AV node. And I hope this is understandable for myself and some others. Really, there are many descriptions on the anatomy of internodal pathway, but it's really difficult to understand the three-dimensional point of view. But from this view, we can recognize how we can approach this internodal pathway when we make an intervention on atrial fibrillation or atrial flutter. Okay, and then the next is a ventricular anatomy. As you know, ventricular anatomy is different from internodal pathway in the atrium. They have the His bundle. They arise from the AV node, where is the here's the triangular cohort, and they penetrate. Bundle goes at the inferior rim of the membranous septum, and it comes to the surface right away from the left ventricle aspect, where mitral, aortic, fibrous continuity is here, and membranous septum here is. So here is the left bundle opens at subendocardial surface. In fact, we are lucky to examine the sheep heart where the membranous septum was muscular. So in that case, there is some muscular tissue around here. So variation in human may be some additional musculature, some rudimentary musculature around here that may cause triggering point of AV, the ventricular tachycardia. And this is left bundle, and it is descending almost to the apex covered by sheath and turn around to make a Purkinje system to cover all ventricular myocardium so that ventricular contraction start from the apex part to the base so that it can make an efficient contraction from here. And on the right side, the right bundle and right bundle branch is intramyocardial course. So not on the surface, but it's in the intramyocardium, make some several branches to here, and they have some moderate band. Sometimes they make some division of like this, and so on. Also, the popular and we are often asked where the ventricular tachycardia is triggered by in the normal, structurally normal heart, but we understand that as we can see here, the muscular tissue in the right ventricle fade away to this level, so that pulmonary valve is attached here, but the real transition from the myocardium to fibrous smooth muscle layer of a pulmonary trunk is around here. So if you examine microscopically this area, there are some islands of individual or groups of muscle cells around here, which is similar to myocardial sleeve in pulmonary veins and similar to myocardial sleeve in coronary sinus to the ligament of Marshall. So this part becoming the point of triggering point for ventricular tachycardia. So in the normal, the myocardium is healthy and not vulnerable. They produce a little impact to the whole ventricle, but by the increased automaticity, and they may produce some premature contraction and so on. Similarly, we have a similar mechanism in aortic summit area, where this thick muscular tissue fade away to aorta, similar area. And also in papillary muscle, the tip of the papillary muscle, they may have some fading away, some islands of tissue. So that's a current hypothesis from the anatomical point of view. One important point I want to emphasize is that physiologic study may demonstrate the current state of activation and possibility of activation. But when those areas is removed or damaged, and then the second part, alternative pathway, may activate, such as when the sinus node is not active, then other part may behave similar to. So anatomical mapping may be more sometimes as important as the physiologic study, so to make a possibility of some recurrence or something like that. Any question, please? So the next part will be demonstrated by Professor Jung-Sun with Jeong.
Hello, everyone. Yes, okay. Today, I'm going to present some typical case of a congenital heart disease, which have normal ventricular topology. This is the first case. When you look at the front side, we can recognize a patch in the front of the pulmonary trunk. So when you open the right ventricle, okay. So this is another patch to close ventricular septal defect. And also there's some spots where some infundibular muscles took away. So this case is TOF. So in this case, let's see the position of the conduction system. So AV node would be present in the normal position, where is the behind the membranous septum, the lower portion of the atrial septum, and then it is connected to the his bundle, which runs on the edge of the ventricular septal defect portion. So this bundle runs like this way, and then makes bundle branches. So when you close the ventricular septal defect by patch, this portion, so the posterior inferior rim of the VST is the portion to be cautious. Well, after operation, I heard that there might be some arrhythmia, post-operative arrhythmia. Is it right?
Yes.
Yeah? So the case may be related to the artificial patch attachment, like this portion and also this portion. And maybe, as Dr. Sa already mentioned, there are some aberrant myofibers around the pulmonary trunk. So they might be the reason to make arrhythmia. Okay, so then let's go to the second case. This one is a much bigger heart to easily seen. So when you look at the heart from the front, there's a big conduit. I think this is Rastelli operation,
Yes.
something like that. So this opening was made newly. And here is the ascending aorta. And at this moment, I cannot recognize the pulmonary trunk insertion site. So let's see the inside of the heart. Well, let me see. So this is the septal leaflet of tricuspid valve. And so here is the septal portion of the right ventricle. And so this is the conduit insert site. And then we can recognize two outlet portion of the ventricle here. So at this moment, this one, which is supposed to be pulmonary valve, is closed, and this part is which is aortic valve is open. So it goes to the ascending aorta. So aortic valve actually is positioned in the rather rightward and also anterior portion. And then there is a ventricular septal defect here. So so we can call it subpulmonic VSD, right?
Yeah.
So it's basically it's a kind of the Taussig being anomaly. So in this case, we already have seen the bundle branch position in the TOF. So bundle, the atrioventricular bundle position is is positioned depending on the position of the ventricular septal defect. So this ventricular septal defect is subpulmonary, but also is still perimembranous VSD. So in this case, the bundle AV bundle is present on the limb of the septal defect. So then, the position of the atrioventricular bundle is dependent on the position of the ventricular septal defect. So this one has a different type of the VSD. First, maybe it's better to look at the outside. Here, we can recognize only one main arterial trunk. So we no separate pulmonary trunk aorta. So this is the truncus arterius case. So in this case, most of them are associated with the subarterial VSD here. So underneath the common valve. So in this case, if we look at the atrioventricular bundle, then so AV node is the right position, and then it goes underneath membranous septum. So it's nothing to do with the ventricular septal defect portion. So atrioventricular bundle is remote from the VSD. So it's easily closed by patchy. Yes. So Next one, it looks very wide ventricular contour. So, but the aorta and pulmonary trunk positions are normal. And then when we look at inside of the ventricle, so we can recognize breathing leaflet here and then lower portion. And there is a big hole at the junction of the interatrial septum and interventricular septum. So this is case of a atrioventricular septal defect. Compared to the previous one, the septal defect portion is very wide, and atrioventricular junction is not separate, so common junction. So we cannot, this case, AV node position is different from the normal position. So the atrioventricular node would be present the posterior part of the atrial septum, which is connected to the posterior end of the ventricular septum. And then atrioventricular bundle runs also on the rim of the septal defect portion. So the atrioventricular bundle would be very long and then make a bundle branch this way. Okay. This is the last case I will present. This patient was a 42-year-old man, so it's adult. So from the outside, so the position of the great vessel is normal, and right ventricle looks larger compared to normal one. So something happened of the inside of the right ventricle. So let's look at inside of the right side of the ventricle. So this is the coronary sinus. So this part is the fossa ovalis. So this portion is the original atrium, right atrium. Then this part should be ventricle. But the septal leaflet of the tricuspid valve, so which is supposed to be attached somewhere here, but we can see free leaflet only here in the middle of the ventricle. And the upper portion of the septal leaflet is attached to the arterialized ventricle. So, but anterior leaflet of the septal, anterior leaflet of tricuspid valve is positioned normally. And let's see, when we look at the posterior leaflet, this one is, so actually, yeah, the annulus is like this. So this part is also attached to the lower portion instead of the normal annulus portion. So this is the Epstein anomaly case. So in this case, then where is AV node? Well, so it looks, the annulus looks like here, but originally it should be here. Yeah. So atrioventricular node present actually basically is normally in the apex portion of the Coe's triangle. Here is the coronary sinus, and this is the original annulus portion, and then this is the tendon of Todaro. So AV node present this area, and then it is connected to the atrioventricular bundle and then make a bundle branch. But this portion of the ventricular septum is abnormal. So it is said that the right ventricular bundle branch can be hypoplastic or even absent. So these are all I will present today. And then next part to be presented by Dr. Seo again. Yes.
Thank you, Professor Kim. If I add a little bit more about the AVSD heart, I will extend my description on the internodal pathway that AV node is here. So internodal pathway from sinus node to AV node is not possible from the usual anterior internodal pathway to approach this. The only way is that the anterior internodal pathway at the transverse pericardial sinus turn around this supra tricuspid vestibule to approach this area. So the Bahamas bundle is should be very important pathway in AVSD, and only this part and crista terminalis part two pathway approaching AV node from the posterior. So there's no anterior connection to the AV node. So it may be important to preserve these two pathways when we deal with the atrial arrhythmia in the AVSD patient after operation. Our interesting study on the conduction system of the heart by Professor Bob Anderson was that on the corrected transposition, which was very curious and very important observation on conduction system in congenital heart disease in 1970s. So what he described from the conduction system in corrected TGA and some abnormal heart with isomerism was that the location of the AV node is different from the normal conduction system. That's because the conduction system is related to ventricular anatomy. So when we think about the atrioventricular septum, which is between the atrium to the ventricle, in the normal heart, right atrium has a septal separation from the left ventricle at the muscular part posteriorly and anterior part membranous part. So in the normal heart, from here, we have a muscular atrioventricular septum here and membranous atrioventricular septum here between right atrium to left atrium. But in corrected transposition, because it's mitral valve, not tricuspid valve, the attachment of mitral valve is superior to the left-sided tricuspid valve. So therefore, in this heart, the mitral valve attachment is higher, and there is a if we pin this part, it approaches directly to the left atrium, and from right atrium, it's not possible to approach left-sided right atrium without going into the left ventricular chamber. So this reversal of the atrioventricular septum makes a problem to locate the AV node and triangular cohort in this heart. So in this, we can glue this heart to show, to make this is to paraffin cube to make this heart CT scan to copy this heart by CT. Here we can see coronary sinus, but the attachment line of tricuspid valve is absent, but only mitral valve is here. So we can make, hardly make, we may think this is triangle core, but it is not on the atrial ventricular septum, but it's only atrial septum. So it is not usually expected the AV node located here, but it locates around here anteriorly, and sometimes two AV node has a sling like this, and so the anatomical observation on this heart, the location of AV node usually comes around here, and then the AV node has a penetrating bundle anteriorly to the left ventricle to here, so that the when we close VSD from this heart, we have to very cautious to suture this part, and when we have to enlarge this VSD, we have to enlarge this part, and we have to very cautious to make the pulmonary stenosis. We cannot cut this part to make a pulmonary stenosis bigger. So this is an anatomical observation of a conduction system in corrected TGA, and it is a very important clinical implication when we have pulmonary valve or pulmonary hypoplasia, pulmonary artery, as in this case. So we have to be very cautious when we have a pulmonary stenosis. Finally, the widening the so-called interventricular communication or VSD. For example, in this heart with univentricular heart of left ventricular type with rudimentary right ventricular chamber anteriorly located, we have a small ventricular chamber and VSD. But this VSD is obligatory component of left ventricular outflow tract when there is this part is an subaortic area. So we have to enlarge so that we remove subaortic stenosis. But we have to cautious where is the conduction system supplying these two ventricles. If this conduction supplies only this right part, it doesn't matter, but it supplies the major ventricle also. So if you open like this, we have this mitral valve or tricuspid valve or common valve at the major main ventricular chamber like this, and we can see right-sided and left-sided ventricular septal crest, and then we can make a hesitate how to enlarge this defect. As you can see, this hypertrophied outlet septum or ventricular septum is a really problem when we have this kind of morphology, and to make a Fontan procedure to make this single heart to make support the aorta. So current understanding is that it is not necessarily related to ventricular topology. That means if we the ventricular septal alignment is far from the crux cordis, where the atrial septum is here, crux is here. So crux, when the ventricular septum meets the crux like this, it is double inlet right ventricle with rudimentary chamber here, and if it is left ventricle here, it is right ventricle and crux is here. In that case, conduction system is always approaches from the crux, but because the alignment of ventricular septum is here, it may be like this or it may be like this, but it really doesn't matter from the viewpoint of a crux. So we usually understand if we have this kind of anatomy, we think this part is usual pathway. But clinical experience and surgical experience has found that it is not always the case. So we have to very cautious both sides to make a problem. But the only way we can do is that to make an apical part to remove some of the ventricular wall, so that we make a little bit of and also it may be also important to remove more right ventricular aspect of this part rather than removing this left ventricular aspect of this part, because when the left ventricular conduction is subendocardial from this way or this way, so we have to make a resection like this, and it's really a difficult case situation when the surgeons operate these cases. So there are still not enough understanding for the human heart, but we are fortunate to have a tool for electrophysiologic study to have this kind of situation, and also by making our strong effort to overcome the every issue of congenital heart disease, we can eventually help the patient, their family, to have a better survival and better quality of life, and so on. Okay, I think we have studied the several specimens, in particular emphasis of conduction system, and I hope you can enjoy. You have enjoyed this session.
Thank you.
Anyway, we should close this webinar now. So thank you for all the audience and the panelists, speakers. And as time passes, as we experience more, our webinar system getting better. We are so satisfied about that. In next year, we do not know whether we will have a webinar again or not, but we will try to make a better seminar for you. Thank you. Bye-bye.